Hello, everyone, and welcome to the next episode of As the Walker Turns. I am Mandy Hampton, and I am joined today by Carly Florence, who is a geriatric nurse practitioner. Did I get that right?
Yes.
Okay, good. So let's start out, Carly, with can you explain to people or even to me, what is the difference between a geriatric nurse practitioner versus a nurse practitioner versus an RN, a doctor? So many acronyms.
There are, right. Registered nurses, they are trained to care for individuals either in a hospital setting or like through outpatient clinics or home health. And they follow orders given by a provider, and that can be by a nurse practitioner, a physician's assistant, or a medical doctor or MD.
Okay.
Registered nurses can go beyond and can ex- sorry. Um, so registered nurses can further their education and obtain a degree as a nurse practitioner, either as a master's or a doctorate degree. And there are a few different types of nurse practitioners programs. There's adult gerontology, primary care and acute care, and family nurse practitioner, and psychiatric nurse practitioner. So as a geriatric nurse practitioner, or sometimes seen as GNP for short, it is that advanced practice provider. So we have that specialized training where we can assess, treat, diagnose, prescribe medications. But as a geriatric nurse practitioner, we understand the specific and unique health needs of older adults. So while general nurse practitioners care for patients across the lifespan, GMPs focus more in on what happens to the body and mind as it ages. And that means we're really tuned into things like memory changes or how medications affect the older body differently, and how to keep someone on their feet or eating well when their appetite drops. And so in a living community, one that really focuses this really kind of care focuses on what can really make a difference. So we're not just treating diseases, we're really helping the residents live comfortably, stay independent as long as possible, and help them feel like themselves, even when their health does change.
Wow, that sounds pretty great. So if I had the option, well, I guess I should ask Carly. Let me back up a second. Is it hard to find geriatric nurse practitioners? Are you kind of like the unicorns of the medical system right now? Are you highly sought after, or is it easy to find?
So I would say it's not as common as a family nurse practitioner for someone to specialize in this area. It is possible for family nurse practitioners to receive additional certifications and receive additional training for a geriatric specific population. Um, but since it is such a unique field, it's not as common. But definitely something I hope to see, as we know this population is growing.
Yeah, you're going to have a never-ending list of patients, as we've talked about in other podcasts, with just the explosion of the boomers. We don't have enough housing, let alone people that can practice medicine to take care of them. So, talk to me
Right.
about, so if you are lucky enough to have a geriatric nurse practitioner available to your loved one or to yourself, what are the benefits? So you talked a little bit about specializing in the common diseases and kind of like the holistic lifestyle of aging, but what do you think, or maybe a couple of top reasons why we should pick that over just your normal nurse practitioner that you may have had for years and years?
Yeah, I think that's a great question, because we are specialized in this time frame of someone's life. We understand what is normal aging and what's not abnormal. So we can look at things that, if there are changes, that they're not being that it's addressed appropriately, but also if if there is components that are normal, that we are able to provide that education to the patients and to family and support the natural aging process. Something that I think in our healthcare system isn't as done as well, that we're used to seeing a very treatment focused care plan where we're looking at adding medications, procedures, hospitalizations, instead of really looking at what is happening and is this normal? And we are able to help differentiate the two things.
Right. Yeah, I would agree, especially. I don't think I've shared this with you with Carly, but some of the listeners are aware that my mom has early onset Alzheimer's. And
Yeah,
so us trying to figure out what is normal, part of the aging process, and what's not normal, as far as her disease. And also, we had to go through a pretty big medication reconciliation a
mm-hmm.
couple of months ago and just kind of really parsing out what is urgent, what is needed for to keep her as healthy as she can be and emotionally sound. But there are other medications that at this point aren't making an impact in her life. And so yeah, it was an interesting family conversation, to say the least.
Absolutely.
Yeah.
Yeah.
So what are some of the misconceptions or common themes that you see from family members or even from residents, as far as I don't know, what do they think that I don't know how to phrase this. Like, what do you hear that they think might be normal that isn't maybe normal, or what they expect the outcomes to be versus they end up being? Or is there anything that comes to mind?
Um, that's a good question. Functional changes, functional decline, cognitive decline, appetite,
Mm,
those things are going to change as we age. And then if there's chronic conditions on top of that, it's educating on that disease process, right? If someone has heart failure or chronic kidney disease, how that affects the natural aging process as well. Um, and so there's definitely a lot of components, and being able to provide that more personalized level of care is so important, because if not, we see that they're just hospitalized because we're concerned that there's a change when we don't, when maybe family or staff isn't educated that this is normal, but maybe we can provide symptomatic support and education to support both the patient and the family.
yeah. So let me go down this little rabbit hole here. So it seems to be what I've seen over the 20 something years in this industry is that food and appetite is a big trigger for especially the families. And towards the end of life, again, I'm not a medical professional. I've just seen this enough to know that, people's appetites and their ability to eat and drink like we normally would, it decreases and then eventually just, stop. So what are some of the things that as me as a family member need to be watching for and, try to come to the acceptance that, forcing mom to have, I don't know, a taco when she's not interested in having a taco, is that, what does that look like, and how can we try and better support, our loved ones, as opposed to feeling that guilt and forcing, the residents or their family members to, try and eat or drink as much as they thought
Yeah.
they should be or they think they should be.
Yeah. And that's something I see every day. And I think um, having that assessment to know that it's not due to an underlying cause. Like, are they having pain when they're chewing? Or as we age, also the muscles in our throat start to weaken, so it can be difficult to swallow. So there's other components to that my hope as a geriatric nurse practitioner, I can provide that education to the family.
Mm-hmm.
And we look at what are the patient's goals, right? Like, they're not going, if family's not there and they're not, maybe forcing them to eat, what would the patient do? And is that quality of life to that individual? And if it is, we look at how do we support them in that, in their goals, right? If that's looking at their favorite foods, or if they do like protein supplements, sometimes we will add those in.
Mm-hmm.
And then hydration, it's one of the biggest problems I see is dehydration. Just because as we age, we lose that sensation for thirst, and so many also, in addition to that, may not be drinking because they don't want to go to the bathroom all the time, and
Right.
so yeah, it does take also the collaboration with the care team that I see it where they have that water bottle in their room and it's filled up whenever they get their medications, and just a simple reminder from staff to be drinking water can help prevent even mild dehydration.
Yeah, I mean, and you know better than I do, but boy, dehydration can cause all sorts of issues, falls, and then it's the common UTI situation, and then
Exactly.
I mean, whoa, I've seen some crazy stuff with people with UTIs. So,
Yeah.
yeah, those are all things that I didn't know that. Thank you for teaching me that as you age, your ability, or I guess your sensation for thirst decreases. I didn't know that.
Yeah.
Okay, well, thank you for that. Um,
Yeah.
what do you see as some like common overlooked health concerns with residents if you're taking them on as a new patient? What are some things that typically get missed that we should be on the lookout for?
I would definitely say that issues related to medications are something when I admit a patient, I'm looking at their medication list that likely has been created from years of chronic care management with either a primary care provider or an outside combination of specialists. Maybe there's been hospitalizations. And so this list has maybe grown without having a full met reconciliation completed.
Mhm.
And so that's definitely something that I look at with my patients regularly, because we know that medications can affect things like their balance, their mood, cognition. And so I do a lot of medication reviews to catch those things before they do turn into a bigger issue, like a hospitalization because of a fall or a side effect from these medications.
And then never forget the additional supplements that someone wants to just throw in on top of it, right?
Exactly. Yeah, there's such a high pill burden. And for individuals as they age, they're like we talked about, that they can come with difficulty swallowing. And that's, if we can reduce the number of medications they are taking, but still treating their disease process or deficiencies, that's going to be the key.
Okay. So that those conversations I found personally and professionally to be a little tricky at times, right? Because someone is like, pro supplement or pro this medication or anti that medication. It could become a very contentious or passionate, let's just say, conversation.
Mhm.
So, from your perspective, how would you like coordination to be? Obviously it'd be great if everyone's holding hands and on the same page. Often that's not the times or often the outcome. So what does success look like to you when you're dealing with a new patient?
Yeah, I think understanding what the patient's goals are. And so having that sit down conversation with the patient, with caregivers, anyone who is involved in that patient's life, if, family members, that everyone's on the same page of what this patient's goals are. And sometimes it does take someone like a geriatric nurse practitioner to help really explain what their goals are based on how the patient is either acting or presenting or how they live their daily life. And so, when a patient is, refusing medications or they're not eating as well, not drinking as well, we have to understand that they may family may still or want to continue, a full scope of treatment. We have
Mm-hmm.
to see, is that in the best interest of our patient for where they're at right now in this stage of life? And so I think if that can be our foundation, if we can all get on the same page of defining what the individual's goals are, and then I think most people, we can get on the same page of for a treatment plan of, is it eliminating unnecessary supplements, medications that may not benefit them at this stage of life, and being able to provide that education to them that this isn't about giving up or not treating conditions, but it's about maximizing this individual's quality of life.
Absolutely. Um, so let's just say that the resident isn't able to communicate what those goals are, for
Mhm.
a variety of reasons. Do you typically then default? Hopefully, they have like, something written down, as far as their wishes are concerned. Do you typically default to that, or are you looking for to the family to kind of drive those decisions?
Yeah, so this is where I'll plug having an advance directive in place.
Yes, yes.
So before an individual, I mean, even if are in a young state that you have a family member would trust with your medical care, filling out that advance directive so that your healthcare team knows who you would trust with medical decisions if there was ever a situation that you weren't able to make decisions for yourself. These advance directives are used in my practice, and it helps me know again who that individual is trusted with medical decisions. But I also um, definitely include anyone else who wants to be involved and shows they have the best interest in that patient's care. And then, even though the individual may not have capacity to make safe decisions, they still have the right to refuse care. And sometimes
Absolutely.
that's so hard for us to understand as family members, to see our loved one refusing care that we know may benefit them or prolong their life. And so I help everyone understand what our abilities are in the healthcare system of supporting that individual. And if they do have cognitive changes, that's still, they're still a person, right? They're still a person who has the right to decline medications or decline a shower. And that's one reason I like to have these meetings, is because I get to know from family, how did this individual live their life? Were they someone that they went to their doctor every 3 months as they were, scheduled to do, or every year they had their annual physical, that health was very important to them? Or were
Mhm.
they someone that went to the doctor when there was a concern? They weren't always taking their medications. And so that helps, me know how this individual may see their health goals now. And I think that helps maybe families see that it's not going to change now that there is, maybe cognitive decline, or because they're family involved, that individual likely will continue those same patterns the rest of their life. And so,
Yep. The essence of who people are doesn't really change, does it? They just get maybe a little spicier.
exactly. Oh, I love the spiciness. And really, just how can we support them in that, right? Like working with our memory support team or assisted living team, and how can we find out, when does this individual, maybe they like to shower in the afternoon, so we
Mhm.
we kind of move things around to fit that individual's preferred cares, or
Sure.
when they like to receive cares, and family can be really help provide a lot of insight for that.
Yeah, I think that's a really good tip for families if they are struggling, or residents with, shower schedules. I know that tends to be a really big trigger. Yeah, I would go back to what was their routine, even maybe in their, like, I don't know, teens or 20s. Were they a morning shower person, evening shower person, twice a day?
Mhm.
Everyone came from a different background. So I think that's an important thing. Or, did you hate taking medicine as a kid? You're not going to like it at 80 either. So, those are all
Exactly.
very, very important insights that you may not think about, but may pop up, later on in life as well. Fascinating.
Absolutely.
Um, Carly, what do you think are some of well, let me back up. You visit senior living communities day in and day out, correct?
I do. Yep. I don't
Yeah.
have an office. I tell my patients my office is where they live. So I do. I practice in communities, senior living communities.
So you were remote before it was cool, right?
Yeah. Yeah.
Um, all right. So going in and out of communities every single day, what are some of the misconceptions that you typically see about senior living, and maybe what you think, how they could be corrected?
um, so one of, I think, the biggest myths is that decline is inevitable and untreatable. So when usually there is that change into maybe they were living independently and now are going to benefit from that higher level of care, is because they're completely there's no hope, right? And
Right.
so I think people often assume that once they enter a senior living community, that they're going to see their family member continue to decline, when in reality, we're going to see that higher level of support. And with that, I've seen individuals really thrive in these communities. They have that connection with people who care about them and they see that, but also they find ways to give back to the community. And I don't know
Mhm.
about, I think for all of us,
Yeah.
being able to give back is kind of what gives us purpose, right? It's our, what, you know, we give back to our families, we give back in our jobs. And so as we age, that doesn't change. And so what I love about these senior living communities is they find ways for individuals to give back and have impact in their lives.
Oh my gosh, I love that so much. I firmly believe everyone has a reason and has to have a reason to get out of bed every day. And, we all know that loneliness is, what did they say, the equivalent of at least a pack of cigarettes a day. And that without one medication or a shower or an escort, we provide that in spades, right? You cannot possibly be lonely in senior living. There are so many people around at all times of the day. Um,
Absolutely.
so, Carly, of all the things that you could have chosen for your career, why did you land where you landed?
Yeah, so my background is in the ICU. I worked for as a registered nurse in the ICU, so I saw a lot of that end stage organ disease
Mm,
and a lot of patients and families who didn't have these conversations about normal aging and chronic disease progression before that happened, right? Before they were in an ICU, maybe hooked up to a ventilator, and that family member isn't able to tell them what their wishes are.
right.
And so really drove me into this practice of one treating our that elderly population and talking about disease management a lot sooner and goals of care a lot sooner. So now I get to do that every day. I get to be in the comfort of someone's home that they invite me into and let them take over the reins of their care. I think a lot of times with this population, they're used to having a treatment plan that was made up for them. They were told what medications to take, how often to take them, and either they did or they didn't do those. But now, as a geriatric nurse practitioner, my hope is to give individuals that control back. They tell me what their goals are, and I get to be that bridge of what does medicine look like? What are options are available so that they can make an informed decision about their health. And we make a treatment plan they're that really they're the head of the table of.
Oh, I love that so much. I think as you get older, I think there is a perception or maybe a misperception that you lose control and you lose the ability to make your decisions, which is certainly not what our goal is. And I think having that frame of mind is incredibly empowering to say, this is how I want to spend the next, 5 years or 10 years or whatever it is. And yeah, I'm the head of this. I'm the captain of my own ship. And I hope you're all going to be here to support me in my decisions. So what an incredible blessing to have that, as opposed to, yeah, being in an ICU and being completely unable to make those, critical decisions and putting that on other people. I've been there, and
Mhm.
I don't recommend it.
Right.
0 stars.
Yeah. It's not a good place to be in. And so I definitely like having those conversations a lot earlier than maybe some people expect, or maybe surprised that I'm discussing that. But it's because the sooner we can have those conversations that they get to be a part of is going to lead to a better quality of life for that individual, right? The rest of their life, they have planned out what they want it to look like. And their family, whether, it's going to be hard either way that you're seeing a family
Right.
member decline, but knowing that they know what their family members' goals are, and they can feel confident in supporting them in those.
Yeah, and I think from, sitting in the chair as a as the daughter, with my mom, and I understand logically what the disease process looks like, but emotionally to know that my mom made these decisions, with what her intent was, and we are all here to support her in that, takes a lot of the burden off, and the responsibility of some of those end of life decisions that some people just really really struggle, whether it's guilt or whatever emotion is driving it. So I'm very very grateful that we have her plans in place, and there's no question as to what she
Mm-hmm.
wants.
Mm-hmm. I'm so glad
Oh,
you have that.
I am too. Took a little bit to get that done, but I'm very grateful we had those tough conversations way
Yeah.
ahead of the game. Well, Carly, is there anything else you wanted to share with us, about what you do, or about the industry?
I think that if I would have to say anything, is that sometimes we see that um, people may expect that now that they're going into a community that their medical care will slow down, when in reality we're often more proactive, because we see these residents regularly, right? I'm involved in what their daily life looks like. I know what their baseline is, and so we're not waiting for a crisis to happen. We're trying to prevent that, and I think that's a huge part of why I love this work, is because I'm often seeing the residents that we're avoiding those hospitalizations, and we're really putting their quality of life at the center of everyone's care.
I love that, Carly, and I can. I don't know if the right word is testify, but my mom, same thing. She has more oversight with her care, in the last year than I think she had in her entire life, and I do think that that has prevented hospitalizations and undue suffering for her. And so I think that's great for people to think about. Just because you're going to senior living doesn't mean that you get this list of meds and you're forgotten about it. It is a whole team approach to make sure. We're doing the best we can, under, with their conditions. So that is very wise advice.
Yeah.
Oh, well, thank you so much, Carly, for your insights and serving such
Absolutely.
a beautiful population. I call this sacred work, and we're very grateful to have you.
Thank you so much. I've enjoyed being on today.
Thank you. All right, everyone. Well, thank you so much for joining, and we'll see you next time. Take care.